بحضراتكم في ليلة من ليالينا من اليمن السعيد. شرفنا بالحضور والمحاضرة القيمة إن شاء الله دكتور الجميل المحترم دكتور عمر الجنيد، بيدياتريك كارديولوجيست كونسلتنت. يا أهلا وسهلا بحضرتك يا دكتورنا.
حياك الله أخي، بارك الله فيك. نبدأ ولا
اتفضل
لسه؟
نبتدي إن شاء الله. الجميع منتظر والحضور جميل الحمد لله، منتظرين تبسيط المعلومة
إن شاء الله.
وحضرتك أهل لها.
بسم الله الرحمن الرحيم. شهر كريم مبارك علينا وعليكم إن شاء الله تعالى. أسأل الله أن يجعل هذا الأمر في ميزان حسنات كل من شارك فيه ومن قصد له أن تكون الحسنات. بارك الله فيكم. اليوم إن شاء الله تعالى نتكلم عن just an introduction في الكونجنتال هارت ديسيز. معروف أنها عبارة عن سبيشاليتي.
معلش هو الصوت شوية ضعيف، مسموع بس ضعيف شوية. معلش فاللي هيبقى عندهم النت واقع يا دكتور عمر هيبقى
خلينا
أو
نشوف
ضعيف، هيبقى الصوت
عاد
صعب.
في شيء مثلا نرفع فيه الصوت. لحظة نشوف. setting. طيب الآن كيف الصوت؟ أفضل؟
ممتاز.
إن شاء الله يظل كذا، بس أصل الصوت نفسه من المصدر نازل فيه شوية زكام وحاجات، هو من
سلامات
المصدر.
سلامات.
يلا إن شاء الله نستطيع نكمل المحاضرة على خير بإذن الله تعالى.
ظهورا يا حبيبنا تمام إن شاء الله.
حياك الله. our objective today إن شاء الله تعالى it will be simple. So we will try to cover two important points in the congenital heart disease. The first one is an introduction or general approach to all congenital heart disease, cyanotic and acyanotic. The second point is what is the critical congenital heart disease definition and what is the main point to address such congenital heart disease that we call it critical. I will not aim to go to take a very complicated take-home message. I will try only to make it simple take-home message at the level of the pediatric level, general pediatric or even general practitioner. By definition, any lesion we call it congenital. That means it is a lesion present at birth. Same for congenital heart disease. It is a defect that present at birth. How we can approach any congenital heart disease? Like initially clinical approach, like any disease, you will start by collecting clinical data, history and examination. Then you will go to the simple investigation like ECG and chest X-ray. Then you will go to the specific investigation. In the pediatric cardiology is the echocardiography. Mostly we are stopping here. Mostly it's clinical, ECG, chest X-ray, echo, then we get the final diagnosis. In very rare occasion, we can proceed to go for CT scan, MRI, or even catheterization. But today, we aim only to approach the congenital heart disease by these three only, by clinical, ECG, and chest X-ray. And even in the clinical, we don't aim to take all details. We only use one information from the clinical data, then one information from the ECG, then one information from chest X-ray. That by answer three questions, we can at least reach to the category of congenital heart disease. So let us use these simple tools instead of going always to the complicated tools. This is the overall approach, but we will divide it to the two categories, cyanotic and acyanotic. And I will start first by answer the three questions. The first question always you will ask yourself, is this congenital heart disease that is suspected still, is it cyanotic or not cyanotic? This question is not easy to be answered, by the way, but if you can answer it, that is good. So clinically, how we can say this is cyanotic, and how you can also say it is mostly cardiac cyanosis, not only cyanosis, because cyanosis can be cardiac and non-cardiac. But let us see the easy things. Mostly the cardiac cyanosis is associated with what we call it inappropriate respiratory distress. That means the patient has significant desaturation while he have no significant distress. So there is no good correlation between the two. For such cyanosis probably is cardiac. The second very important point, cardiac cyanosis mostly have no good response to oxygen support. So you will have the patient has drop saturation. If you try to give him oxygen, he will not show you a good response. That means saturation will not increase more than 5% from the baseline. And this because the oxygen support is going to the lung, while the cardiac cyanosis caused by shunting of blood from the right heart to the left heart directly without going to the lung. So even you provide the patient oxygen through the lung, but the cyanosis, because of shunting inside the heart, it doesn't go to the lung in order to carry more oxygen. So cardiac cyanosis mostly not improved with oxygen support. Some point, many people they are mentioning it, that the cardiac cyanosis is worsening by the crying. Yes, it could, but also the others can be also worsened by crying, especially the lung. So worsening by crying or not worsening by crying is not a big deal. The most important two things to make the cyanosis probably cardiac is the first 2 points. So this is from the clinical side about the cyanosis. We have another slide, next slide about this. Just let us compare with the next question. The next question is, what about the pulmonary blood flow? That is in the chest X-ray. So either this chest X-ray, it will show you increased bronchovascular marking, or will show normal or decreased bronchovascular marking. The first one, we call it plethoric lung. The second one, we call it, if it's decreased, oligemic lung. Some approach, they try also to incorporate the cardiothoracic ratio, that means the heart size, in the approach, but the more simple approach, they don't include this. So the second question, by looking to the chest X-ray, you will see if this lung is plethoric, that means more congested than normal, or oligemic, or normal even. That is less blood flow to the lung. The third question is, which ventricle is dominant? Usually we get this information from the ECG. So look to the ECG. If there is signs of right axis deviation, right ventricular hypertrophy, that means the right axis is the right heart is dominant. In the opposite side, you can have also the left side dominant if you have the left axis deviation and the signs of left ventricular hypertrophy. The axis deviation is not only because of the muscle bulk. It could be also caused by either ipsilateral increased muscle bulk or contralateral decreased muscle bulk. Sometimes you can have both. For example, right axis deviation because the right ventricular hypertrophy, and in the same time you have left ventricular hypoplasia. For the axis deviation, either to increase the muscle bulk in the same side, ipsilateral, or decrease in the other side, the contralateral. Sometimes also the bundle branch block, it can cause axis deviation, and in rare occasion, the pathway or the track, that is the conduction system run through, it can give you also axis deviation. But generally, from the ECG, we can decide which side is the dominant. So if you answer these 3 questions, you can approach the congenital heart disease simply. I will have also another extra slide for this first question, another extra slide with chest X-ray for the second question, and another extra slide for the third point with ECG demonstration. Let us go one by one. For the cyanosis, if you look to this picture in your right lower hand, easy to say this patient has cyanosis. Clearly, there is bluish discoloration of skin and mucous membrane. For such cyanosis will not miss in the clinical practice. And easy to say this patient is cyanotic. And almost this patient have saturation less than 80%. But the problem, there is a gap between the saturation that can bring you clinical cyanosis and the saturation that is still abnormal, but it will not give you clinical cyanosis, which is saturation above 95, it will not give you cyanosis. This is normal. Between 95 and 90, it could be accepted for a limited time, but also it's not normal. But below 90, from 90 to 80, is still abnormal, but many times it doesn't give you clinical cyanosis. So what is the solution? With advancement of technology, we are using now the pulse oximeter. So it is easy, simple, and by using this device properly, you can categorize the patient who has normal saturation and the patient who have abnormal saturation. Usually, you are categorize the patient like this. If the saturation is 95% and above, that is normal. Usually for limb or pre and post ductal saturation, this one. If the saturation is abnormal, that means less than 90%. The number between 90 and 95 is the borderline. It needs some repeated investigation and repeated assessment. If not improved within a limit of time, then it could be considered as abnormal and investigate the baby. When you are taking the saturation by the pulse oximeter, as you know, all pediatrician, you have a lot of factors you need to consider. I will not read all this list. I will keep it for you to read it. Even I can send this lecture after I finish as a PDF for all people. But generally, you need to be sure it is accurate measurement by addressing all these factors. So if we assume that we're done with the cyanosis, let us go to the next information. Is the lung is normal or plethoric or oligemic? This is the X-ray for the normal infant or child. If you look to this X-ray, you will see the lung or the bronchovascular marking of the lung. The outer third, you are barely seeing the marking. If you just concentrate and zoom the picture, look, you can see the bronchovascular marking. But generally, it's not easy to see the bronchovascular marking in the outer third. But if you look to the next, it's easy to be seen. Bronchovascular marking in the middle third of the lung, easy to be seen. And in the inner third is prominent. So this is the normal chest X-ray. Prominent in the inner third, clear in the middle, and barely seen in the outer third. This is the normal bronchovascular marking. But if you look to these two X-ray, clearly this X-ray is plethoric because easily we see the bronchovascular marking even in the outer third. Heart also enlarged. But the other one, it's almost barely you see the bronchovascular marking in the middle. This is oligemic, while this is plethoric. But in many times also I need to submit this. In many occasions it's difficult to reach to the conclusion. But generally, if you see plethoric or oligemic, it will shorten your differential diagnosis. So this is the second slide about the chest X-ray and plethoric or oligemic lung. The third one is about the dominance. Which is the dominance? If you look to the first ECG, clearly the lead one and AVF, each one is leaving the others. That means the AVF is negative here, which is indicating left axis deviation. Even the chest lead still normal, but the axis clearly is left axis deviation. The normal one is the one below. See, the normal one is positive in lead one and positive in the AVF. This is normal axis and normal chest lead. While the first one clearly showed left axis deviation by a negative deflection of R wave in the AVF. The third one, which is on your right upper hand, you see here, the negative one is lead one. The negative lead are dominantly negative in the lead one. So these are and these are reaching each others. I'm using this word to keep it easy for you to remember in the practice. So if it's R wave in the lead one and R wave in the AVF reaching each other, this is the right axis deviation. You can support this finding also by find positive R wave in the V1. This support also the dominant side is the right one. If you look to the last ECG on your right lower in the screen, so you see here R wave in lead one and R wave in the AVF both are negative. So if these are negative both, the axis we call it superior axis, which is a prominent in a limited congenital heart disease. Easy, you can list it down. Usually this is the one AVSD or AST primer, tricuspid atresia, and rarely it can be found also in the DTGA and other congenital diseases. But mainly these three in the screen, which is AVSD or ASD primer or tricuspid atresia. third question, which is which dominant is, easy to be answered from the ECG. So if we are using these three information only, we are approaching congenital heart disease by three data. Look to this approach. So the first question, if you answer the patient is acyanotic, so you will look to the pulmonary blood flow. If it is increase or normal or decrease. If the pulmonary blood flow is increased, so go to the ECG. If the pulmonary blood flow increase and the dominant is the right side, usually the shunt is pre-tricuspid, and shunt before the tricuspid valve, which is many occasion the ASD secondum. Also the partial pulmonary venous drainage, anomalous partial pulmonary venous drainage can be also in this area. But so easy to reach to the diagnosis of ASD. See, the patient is acyanotic. The lung field showed plethoric lung, while the dominant side is the right by ECG. So probably the diagnosis ASD. If we go again the same direction, patient is acyanotic and the flow in the lung increase, but the dominant side is the left, then you will have these most famous three differential diagnoses, either VSD or BDA or AVSD, which all are post tricuspid shunt. Yes, all are left to right shunt, but this pre-tricuspid valve, while this is post tricuspid valve. In the other side, if you found the patient is acyanotic and the flow to the lung either normal or decrease, you will look to the ECG. If the right side is dominant, so this is probably pulmonary stenosis, while if the left side is dominant, this is probably aortic stenosis or a lesion like a coarctation of aorta. We approach acyanotic congenital heart disease by simply answering the three questions, and we can reach almost nearly to the diagnosis, either ASD as the first one, or AVSD, or VSD only, or BDA if it is something between the Greek arteries. This is the AVSD demonstration. That means the defect is between both atrium and ventricles. So let us, this is the same approach by the American Heart Association, but here they add the size of the heart. It's a little bit more complicated than the first one, but also it's easy if you follow it like a follow chart. You can use it sometimes, especially if you have a prominent heart size, so cardiomegaly. So you can use this approach also, which is the same, just at the heart side. Let us look to the second group, which is cyanotic congenital heart disease. If you answer the first question, which is the patient cyanotic or acyanotic, by this is the patient is cyanotic or the saturation is abnormal, then go again to the pulmonary blood flow. If it is increased, look to the ECG. If the right side is dominant, you have these three differential diagnoses, either transposition of great arteries or total anomalous pulmonary venous return abnormalities or hypoplastic left heart syndrome. If again cyanotic and increased flow to the lung, that the lung is plethoric, but the dominant is the left side, usually this is a truncus arteriosus. On the other side, the patient is cyanotic and the flow to the lung is decreased, go to the ECG. ECG, if the right side dominant, either tetralogy or severe pulmonary stenosis. If the left side is dominant, either tricuspid atresia or pulmonary atresia with a small right ventricle. Look also again, by answering only simply three questions, we can reach from cyanotic till at least 2 or 3 differential diagnoses. So just look to this simple three questions, answer it, and go to the approach. This is the TGA, which is the parallel circulation, just only the mixing at the level of the atrium. This is just a demonstration for the total anomalous, so the return all going to the SVC. This is demonstration for the hypoplastic left heart syndrome. All they are here in the approach. The last one is the demonstration for truncus arteriosus, and this is for tetralogy of Fallot. This is the tricuspid atresia and the flow coming from the RA to the LA, then mixed in the RV and going to the systemic circulation. This is the same approach for cyanotic congenital disease by American Association of Pediatric, but they add again the heart size, so they make it a little bit more complicated. If you are happy to follow such approach, I will send it to you at the end of the. Let us make a trial here. I need just only anyone who need to participate. He can send in the chat their participation. Look here, this is a 3 months old, 4.3 kg. Saturation is 96 on room air, but the patient is distress. So do we answer the first question? Yes, saturation is 96. That means the patient is acyanotic. So if you look to the X-ray, this X-ray is plethoric lung. So if you just remember the approach, this patient is acyanotic with the plethoric lung, and the ECG showed superior axis because it's negative here and negative in the AVF. If you go back to the approach for the acyanotic, what do you think where we reach? Patient is acyanotic, lung is plethoric, dominant side is the left, and there is superior axis, not only left, there is superior axis. Where we reach here? Any participation from the chat just to make it awake? Anyone, 2 or 3, just to make it interactive. Cyanotic increase, and the dominant is the left with superior axis. These all the differential. What do you think? Which lesion can give us superior axis from these 3? Chat, I will open it. MashaAllah, MashaAllah. True. So this is ABSD. We don't use echo, even we don't need it. We reach to the diagnosis easily just by scrolling the approach. So if you go with the approach, you can reach the diagnosis. Excellent, mashallah. So if you look to the other patient, this is 5 days old, 3.2 kg, saturation is 86. So we answer the first question. Patient is in the cyanotic group. Even clinically, you will not see the cyanosis. And if you look to the ECG, he has left axis deviation. And if you look to the lung, this is a oligemic lung. So if we go back to the approach, just remember the approach of cyanotic here. Patient is cyanotic and the flow to the lung decreased. The axis is left axis deviation. So we have only 2 differential diagnoses, either tricuspid atresia or pulmonary atresia. So we can reach to 2 differential diagnoses by such following the approach. How we can differentiate between tricuspid atresia and pulmonary atresia is not easy by the simple 3 questions, but at least you reach this is a significant obstructive lesion in the right side. So you will have an idea how to address this patient only by answering the 3 questions, which is a very informative approach. This is the approach together. If you put the approach together, it will be like this, but you can use it one by one. So before I go to the second point, and yes, I know you deserve a cup of coffee, but let us give you 2 minutes while you are taking some sips of coffee and just answer for me this question. This is the question. Can we send this patient home or not yet? Read it well. If I have 4 people, they send him home, I will start the next slide. If not yet, so we need to discuss it. Can we send this baby home or not? Read it well. Take 2 minutes. Someone said no. Why no? What else you want? The one who said no, he need to tell me why. But the one who said yes, I don't need explanation. Someone said coarctation. From where you got this diagnosis? Someone said yes. 2, yes. Stable, yes. Yes. Okay. Someone asked a very good question. He said, tell me pre and post ductal. Very good question. I like this question. So I will give you this. This patient, I will tell you the truth. This patient, assessed by the nurse that received the patient from the delivery room, and it put on the lap of the mother. Father is bedside. All they are happy, nurse and parents. And the pediatrician came to see the patient because my nurse, they told him he is lactating well. And this is his data on the screen he saw. And he did clinical examination. He don't see significant things. So he is very happy to send the patient home. But in this hospital, there is a routine protocol. Usually, before sending the patient home, they send the patient to the, what we call it, a program or protocol to screen the baby for what we call it, a critical congenital heart disease. So they send the baby, just only a routine investigation, to the nurse that is assigned specifically for this program, which is better to assign someone who's only for the program, especially in the busy center. If you have a busy center, the primary nurse have a lot of work. It's difficult for her to bring you the complete protocol for critical congenital heart disease. So it's better to assign one nurse for all neonate before going home, need to pass by this nurse. But if your hospital is not a heavy load, you can ask the nurse to do the protocol fully. So we send the patient to this nurse, and the nurse did the protocol, and she gave us this new result. She told us there is 88% saturation in the right upper limb. And she confirmed to us the wave in the pulse oximeter was good. So what do you think? Is it okay? It can depend on this assessment, or you need to do further, to repeat, to do something. Yes, someone he asked to repeat, even with this difference. Okay. We did also, we repeat the test 3 times and we get almost similar result. So what do you think? This baby now, he will go home or he will go somewhere else? Good. There is a very good comment by the chat. MashaAllah, tabarakallah. So what do you think? Is it A or B or C or D? Some people already they answer the question in the chat. But to give the people is a chance to answer, we can wait a little bit. So the question first, is this differential cyanosis or reverse differential cyanosis? You can send D or R. Enough. Reverse. Good. Excellent. This is a reverse differential diagnosis because the low saturation is in the upper limb. See? If you have a coarctation, you will have the low saturation in the lower limb because of this stenotic area. So the flow coming from the pulmonary to the lower part of the body. So the lower part will have low saturation. We call this differential cyanosis. While in the TGA, this is reversed. In the TGA, you will have the upper body already have desaturated blood, but the lower body, they will receive a bitter oxygenated from the PDA. So the lower body will be bitter. So here, reverse differential. So patient diagnosis is transposition of great arteries. See how we jump from a baby who candidate to go home by a rapid initial examination. Just we send the patient to a routine protocol. We bring the patient to a very serious diagnosis, and the patient needs surgery within a neonatal age. We will not send him home. We will send him for surgery after we stabilize the patient. I will not go in details for the TGA. Just only I need to show you the importance of what we call it screening for the critical congenital heart disease. What is the definition of critical congenital heart disease? This is what is written on the screen: systemic low cardiac output or low saturation that is requiring intervention, either surgery or cath, in the first year of life. The article, which is the reference article, I will mention it after a few slides, make the first year is not to make you not vigilant in the first few days, no, but just to tell you any disease mandate intervention, even at age of 10 months or 11 months, still considered a critical congenital heart disease. But to be honest with you, there is a lot of discussion, and many people, they define only the critical congenital heart disease if he need an intervention in the first few weeks of life. Some people, they said 6 to 8 weeks. Some people, they make it up to 12 weeks. But generally, in the reference article, they keep the definition up to 1 year and under the name of critical congenital heart disease. The problem is these critical congenital heart disease are 15% of congenital heart disease. More problematic, it represents 25% of mortality in the newborn. So it is a very serious one. Therefore, early diagnosis, immediate appropriate intervention is very important. And if we are sure this need early diagnosis and immediate intervention, that means we need to decrease all the diagnostic gaps. We don't need to lose any patient from this. Classification of this critical congenital heart disease is to 3 groups to facilitate the understanding of hemodynamic. The first one, the disease that have low systemic output, which is, we call it duct-dependent systemic flow. The second group usually presented with cyanosis, which is duct-dependent pulmonary blood flow. The third one is the parallel circulation, which is transposition of arteries. We also present this patient by cyanosis. So how to decrease the diagnostic gap in such very critical disease? There is 2 things need to do to decrease the diagnostic gap. The first one will be done prenatally. The second one will be done postnatally. In the postnatally, I will explain only 2 points, even there's a lot of things to do, but 2 points, which is, I think, more important. So let us go to know. So prenatal ultrasound usually diagnose only 51% from such critical congenital heart disease. Fetal echocardiography is with better sensitivity and specificity, but even the studies, it brings 60 to 90% only. There is still either 40% in some studies or 10% in the more meticulous studies. Still, these patients can be missed by the fetal echocardiography. What we need to do prenatally is to screen the patient by ultrasound. With any doubt, there is a list of indication for prenatal ultrasound to send him for fetal echo. You need to follow it, especially this is for gynae obs, because they are the one screening the pregnant mother. So any doubt or any indication from the list, they need to send him to fetal echo. And the fetal echo, they need to assess if they are meticulous, they can catch 90% of such disease. Still 10% need to be catched in the first day of life. What we can do in the first day of life as a postnatal to catch such disease, this 4 point is important. Yes, all things in this history and examination can help, but this is a very important point. The first one, you need to be a very good observer. You know, the neonate is not complaining. Only you are the one observing. So you need to do a good observation, full inspection, full assessment as per protocol for any neonate. But specifically, radiofemoral compare, either blood pressure or saturation or pulse is very important to do radiofemoral compare, upper and lower blood pressure and saturation. And then, if applicable in your department, do what we call it hyperoxia test if the patient is sick. We will see it in the next slide. The second one, very important, beside the pulse oximeter or the hyperoxia test, is what we mentioned before in the question, the pulse oximeter screening for the critical congenital disease. We will see it after the next slide. Let us see first what is the hyperoxia test. Hyperoxia test is a test that need to take a repeated blood sample. Take care, is not depend on the oximeter. It need a repeated blood sample. So what you will do, you will expose the patient to oxygen. First, you will take the baseline oxygen, partial pressure oxygen in the blood by blood gas. Then you will expose the patient to 100% oxygen, 10 liter by non-rebreathe mask. Then after 10 minutes, you will repeat again the blood gas that you did in the baseline. So 2 times at least, you will take a blood gas. Then you will see what happened after 10 minutes, 100% oxygen supply to the baby. If this baby has a pulse pressure of oxygen inside the blood gas more than 300, this is the normal one. If fail to get above the 100 millimeter mercury, this is usually a cyanotic congenital heart disease with significant cyanosis, either the parallel circulation or the mixed lesion. There is 2 groups in the middle. It's not easy to be differentiated with the congenital heart disease, but if the result between 100 and 150, this is either persistent pulmonary hypertension or mixing lesion. Mixing lesion can present here, but the parallel circulation always here. And if you have a result between 150 and 300, you can have another non-cardiac disorders like a pulmonary disorders, CNS disorders, or methemoglobinemia. This is the hyperoxia test. The important question coming always in this, is it safe to do hyperoxia test in a patient that we suspect he is a duct-dependent lesion? As we know, the oxygen is a strong stimulator for the duct to close. Is it safe to do such test in a patient with suspected duct-dependent lesion? Can anyone give us a participation? Anyone? No. It may close it. So safe or not safe? Yes, it may close it. Tell me, is it safe or not safe? No, not safe, not safe. So all people, they ask, one said safe, mashallah. And I like the one who come opposite to the stream. But if he has evidence, by the way, I will tell you, most of the articles that is written to assist this hyperoxia test in a patient with duct-dependent lesion, they says there is no proof such test that is continued for 10 minutes, it will induce duct closure, especially if the saturation, it doesn't cross 90%. Some articles even said 85, because the oxygen is a strong stimulator if it is in the higher side. And many of the duct-dependent lesion, they are in the lower side, so they will not build up oxygen in the circulation. Less likely, they said like this, less likely this test will induce the duct closure. But they said there is 2 things you need to take it in your mind. First one, if you are in the area that you can't help the patient, if the duct gets smaller, try not to use it. We have another solution. I will mention it at the end of the slide. If you have in the area, if you can't help the patient, if the duct get more restriction, it's better to avoid this. This is the first one. The second one, it's better also to have a prostaglandin at the bedside if you try this test. Whenever you think the duct start to shrink and the patient start to deteriorate, you will put the patient on prostaglandin, so you will solve the issue that you cause it. So this is 2 points. Keep it in your mind. It's better not to do it. Okay? It's better not to do it. But if you will do it, it's better to keep prostaglandin at a bedside for the patient. For me, I think most of the hospitals here in the Saudi Arabia, they have prostaglandin, but if you don't have a prostaglandin, if you don't have a gun, don't fight, كما يقولون. Keep yourself in the safe side and try to use another method to bring answer for your question. Okay, let us go next because of the time. So we finish this one. Let us go to the more safe, more easy, which is the pulse oximeter screening. as I told you, it's better to have special session to do such test completely. So you will put a pulse oximeter in the lower limb, anyone, and you will put a pulse oximeter in the, not in the left here, this is inverted image, in the right upper limb. In the right upper limb and the in the lower limb, any one of the lower limb. And then you will exclude all the interfering factor that I mentioned it in the previous slide. I don't read it, but I mention it only as a table. And then you will report the saturation. How you can interpret such test? First, the location is pre and post ductal, right upper and any one of the lower. Second, the positive test is any saturation below 90, or if less than 95, with a difference between the upper and lower more than 3, and some articles said more than 5%, or if it is repeated 3 times and continue to be in the gray zone. We will come to see the diagram in the next slide. So these 3 things considered positive. Sensitivity of such test is 76, and specificity is almost 100%. If you have it clearly positive, almost this is specific for the cardiac problem. Possible long-term cost benefit is there. Still, this is the area of discussion. Is it cost effective or not? Many people, they think it's not cost effective, and many other people, they think it's a cost effective. And for me, for the center who have the pulse oximeter is there, they need to use it because there's no additional cost. Unless the center mandate a separated session, separated nurse, separated system to record, that it can add cost, but otherwise the cost is less. You need to avoid all interfering factor that we mentioned before, and it's better to be done after the first 24 hours, because if you do it in the first 24 hours, many false positive result is there. And then after you get a positive, you need to correlate with the clinical finding, and mandatory you need to screen the patient with echo if this test is positive. So send him to cardiology and for screening. This is the reference article I mentioned you. Most of the information about the critical community is coming from this article. So this is the diagram from the same article. You will look here. At any time, you measure the saturation less than 90, this considered as positive, and it will go to the result. We call it failed screening. It will go to the cardiology. At any time, the saturation is more than 95%. The difference is less than 3% between upper and lower. This patient is passed the test, and he don't need to go for the next step. Anyone in the middle, either the saturation between the two numbers or the difference is not more than the 3%, you need to repeat after 1 hour. Again, after 1 hour, if again the gray zone, then after the third one, if still in the gray zone, consider this as a failure and send it to the cardiology for screening. But here you need to mention, for the cardiologist, which type of failure. Right. So just mention to a cardiologist which type of failure. Is he failed, the patient, because he have saturation less than 90 from the first measurement, or he failed because you have a repeated measurement and the patient continue to be in the gray zone, because the disease suspicious is more when you go to more to your left hand. So this is this diagram, easy to be used, but just to know, this is from American Academy of Pediatrics. Saturation in the first 24 hours is not always above 95. You will have 95% after 24 hours. So if you have this saturation the first few minutes or first few hours, still considered as normal. And because of that, better to do this test after the patient pass at 24 hours. This is the categorization of the critical congenital disease. The first group is the left-sided obstructive lesion. The second one is the right-sided obstructive lesion. The third one is the mixing lesion. You can keep it in your mind like this. So the obstructive lesion on the right side is this, either obstruction at the level of tricuspid valve, or the RV is small, or the obstruction at the pulmonary valve or the PA branches. All this area can be obstructed here. Or on the other side, the systemic obstruction, again, it could be obstructive at the mitral valve or hypoplastic left heart syndrome, mitral atresia or severe mitral stenosis, aortic stenosis, or you can have a coarctation, severe coarctation or interrupted aortic arch. All this lesion is obstructive lesion in the left side. The other lesion is either parallel circulation in the transposition of great arteries, total anomalous pulmonary venous drainage, it could be obstructive, which is very serious, or truncus arteriosus, which is a mixing lesion. All these are considered critical congenital heart disease. How you usually, if you diagnose a patient with duct-dependent lesion, which is the big name for the critical congenital heart disease, how you can balance the circulation. Now the patient depends on the duct. If your duct is big, so the flow through the duct is more than that of the aorta. And if the duct is small, the flow to the lung is less than that of the aorta. So the key point of balancing circulation is in your hand. Let us start by the pulmonary dependent. So if the pulmonary flow is depend on the duct, for example, in the picture here, you have pulmonary atresia. Same as tricuspid atresia, same critical pulmonary stenosis, a tetralogy with severe subvalvular stenosis. All they have obstruction of the flow to the lung. Did you see my arrow or not? Clear the arrow? Can someone say yes or no? Yes, okay, good. So if all these lesions are obstruction to the flow to the lung, so the lung flow is depend on the duct. If the duct is big, the flow to the lung is more. If the lung is small, the flow to the lung is less. But see, if the PDA is bigger than needed, it will steal from the aorta. So you will have hypoperfusion to the lower body while you will have overflow to the lung. So you don't need to open the duct bigger than needed. And the other side, if the duct is small, you will have less flow to the lung than needed, but you will have good flow to the systemic circulation. So the saturation will not be maintained. So how we can balance such circulation? It's not easy, by the way. Usually the flow through the BFO here, because see, this is all obstructive. Flow is coming through the BFO to the left side. If the BFO have some restriction, you will have a problem with both systemic and pulmonary. So you will have, if the flow is good, you will have good systemic, good pulmonary. If the BFO is less, you will have bad flow to the systemic, bad flow to the lung. So you will have both perfusion to the systemic and oxygenation, both are bad. But if you have problem with the PDA and the patient who have pulmonary dependent circulation, so if the PDA flow is increased, so flow of the PDA is more, but the flow to the systemic circulation will be less. You will have good oxygenation, but the systemic perfusion is less. In the opposite, if you have less flow to the duct, so the opposite one, you will have low oxygenation, but good flow to the systemic circulation. So how we can balance these things? Let us see how we can balance this. So generally, if you receive 60% saturation from the systemic vein, and this, it will go to the left side where you have 100% coming from the pulmonary vein, this will be mixed together to give 80% saturation in the aorta. So 80% going to the tissue, it will come back only 60% if the patient have normal metabolic rate, because mostly 20% to 25% will be used by the tissue. So if you have this saturation in a patient who have duct-dependent pulmonary circulation, this is usually a balanced circulation. Don't aim for saturation more than 80 or 85 at maximum, because at that time, that means you have a more flow to the lung, less flow to the systemic circulation. So let us go by this table. If the patient have low oxygenation, that means the lung have low perfusion through the duct. What is the possible mechanism? The duct flow is decreased. How you can say this duct flow is decreased? Immediately, when the patient drop saturation, you will go and take a blood gas. if the blood gas showed oxygen low, but lactate is not increased, that means the saturation is the problem. The flow to the lung is the problem. What you need to do? You need to increase the prostate. Also, you need to facilitate flow to the lung by vasodilate the pulmonary circulation by any vasodilator, but mainly we are using the oxygen. So by vasodilate the lung, increase the size of PDA, you will increase the flow in the PDA, so oxygenation will improve. But in the other side, if you have the patient with good saturation, but blood pressure is not maintained and systemic circulation is not maintained also, so the possible mechanism is increase the flow in the PDA or decrease. The possible mechanism is increase flow in the PDA. BF will affect both, but increase the flow in the PDA will improve the saturation, but will decrease the systemic flow to the tissue. So immediately after you have increased lactate, look to the saturation. If the saturation is okay, but the lactate build up, so the problem is the duct is huge. You don't need to go to increase protein as many patients and many medical staff sometimes do. In such situation, you need to improve your volume and you need to decrease protein, especially if you do a echo and you look to the PDA, it's big. And you don't need to increase the oxygen supply. He is maintaining his saturation. Even you need to stop oxygen supply for the patient because all these protein and oxygen supply will increase flow to the lung. While we have no problem with the lung here. The patient has problem with the systemic circulation. This is very important point in the practice. Many doctors, if he saw the patient building up lactate while the saturation is maintained, he will go to increase the prostate. He think this is the solution always. No. And if the patient saturation is maintained, but the lactate is built up, that means the duct is bigger than needed. So we don't need it like this. We need to stop the vasodilator to the lung, which is the oxygen, and decrease the protein dose and observe the duct size by the echo if it's available in order to decrease it a little bit, keep better flow to the systemic circulation. But if both is deteriorated, oxygenation and perfusion, this is most likely either the BFO or the ASD getting smaller or the patient have heart failure. What you need to do, you need to give the patient volume. You need to do balloon arterial septostomy if it is available and you have echo to prove this. And if the heart is failed, you need to give him inotropes. So the management not always to increase protein. Sometimes you need to decrease protein. And also management not always to give oxygen. Sometimes you need to stop oxygen in order to improve such very critical congenital. In the other side, if we have systemic dependent, PDA dependent systemic flow, like such patient, hypoplastic left heart, flow in the right heart is no problem. It's coming to the right ventricle, is running to the pulmonary very normally, but systemic circulation is dependent on the flow from the pulmonary artery through the duct. So this systemic circulation need this duct for the systemic perfusion. So BFO is important for both, still same, but increase PDA flow, improve the systemic perfusion. In the previous example, it was the opposite. So how you can manage such patient? Again, you will see this patient have saturation in the systemic circulation about 80, same, but 60 from the systemic vein, 100 from the pulmonary vein. It mix in the right side and going to the systemic circulation with this 80%. How you can manage if you have a drop in the oxygenation, so drop in the lung perfusion, that means either of the BFO get restriction, so it decrease both, or the PDA, it get more size, so that the flow is still to the systemic circulation. This is the opposite of the previous one. What you need to do here, you need to increase the vasodilator of the lung, but you need to decrease protein here. Even saturation, but you need to decrease protein here. The other side, if you have drop in the systemic perfusion, that means the PDA flow is decreased As we mentioned before, it's by the lactate, if increasing the lactate and the signs of systemic perfusion. So what you need to do here, you need to improve or to increase the protein, decrease pulmonary vasodilators, and give the patient volume. If both affected, that means either the BFO or the heart function is affected as before, so the management also as before. So I will send this slide to you also, just to make a review to it. Is not always the same management in every patient, especially for the ICU. The pediatric ICU, they need to memorize this rule very carefully because they are the one following the patient one by one. I need to tell you a very important information here. The patient who have low oxygenation initially, or the patient who has low perfusion initially, if we don't recognize this early, then later on it's difficult to differentiate between the two because the patient will have mixed presentation. So this is ICU management, or at least a high dependency unit management. It needs the patient to be in the monitored area one by one. If he drops saturation or drip systemic perfusion, immediately you need to prove this by blood gas to see is it the problem of the duct. You need to increase its size or you need to decrease its size and manipulate the parameter accordingly. Very critical things, but also if it is memorized well, it is a very helpful. Now I will give you the information where you have no echo and you feel it's difficult to use the hyperoxia test. And some brave doctor, he can use hyperoxia test anywhere. But if you feel that it's unsafe to use hyperoxia test, use this rule. If the patient is cyanosed and echo is not available to show you the final diagnosis, that you fail to reach it by your approach previous one, because some cases still it will be in the gray zone, just go and look to the chest x-ray carefully. If the chest x-ray like this, congested, white lungs, so put two differential diagnoses. If this patient is preterm, this is probably respiratory distress syndrome, so treat him accordingly. But if the patient is full term, make this differential the second. The first one will be the total anomalous pulmonary venous drainage, which is obstructive type. Okay, if you look to the x-ray and you saw this x-ray, oligemic lung is not our normal chest x-ray. The x-ray will not explain the cyanosis in this one. So in this patient, you need to start him on prostatin, make the provincial diagnosis a critical community duct-dependent, and start prostatin till you prove otherwise. You can send him to the patient, to the cardiologist, to make a further investigation. If the patient only need to open the duct, that is easy to manipulate by prostatin. But in many occasions, the patient is not enough to open the duct for him. He need more than this. For example, the TGA, he need balloon arterial septostomy, and he will not improve by any measurement except balloon arterial septostomy. So you need to go as fast as possible to cardiologist to do this, especially if he has intact septum, intact ventricular septum. So some patient also like obstructive pulmonary venous drainage, you will not improve unless you release the obstruction. Yes, there is some cases it's difficult to be managed just only by clinical approach and simple chest X-ray and ECG, but do your best. Yani approach the patient to the end. Use all the available modalities with you. And also I will give you a secret. If the patient is desaturating badly, even if you try the hyperoxia test, it will not do anything, because usually hyperoxia test, it will not bring the patient to the saturation more than 85. It's also safe to try the hyperoxia test. So by this very limited information, I can reach to what we call it take-home message. First one, I have a 6 take-home message. The first one is to the pediatrician generally. Systematic approach, starting by clinical and simple investigation, is very useful, because we are in the era of echocardiography that is almost solve all questions, almost. But also if you are in the area where the echo is not immediately available, still systematic clinical approach with simple investigation can put you at least to 1 or 2 differential diagnosis in the congenital heart disease. Second things, Echocardiography is the eyes of cardiologist, but it's all the time operator dependent. If you don't have expert one, you may follow the wrong track. So it's better to have a very expert one in the echo, especially with the complex congenital heart disease with multiple association. Critical congenital heart disease, it causes a very significant percent of mortality. It reaches about 1/4 of mortality in the neonatal age. So try to pick it as early as possible. Critical congenital heart disease screening program is very crucial if applied properly, and the balance between both systemic flow and pulmonary flow in the patient with the duct-dependent circulation is very important. It needs a very vigilant monitoring and appropriate support according to the scientific interpretation of the finding. Lastly, if you have a doubt, look to the chest X-ray. If you still not solve the doubt, start patient on prostatin and look carefully to the trends of saturation and perfusion. If the prostatin solve the issue, that means the patient is duct dependent and you hit the proper point. But if the trends is worsening, that means the patient is not a duct dependent. Something else you need to search about it and do your best. I think by this I finished. I'm ready to have any question or comment.
رائع رائع حقيقي. بسم الله. كتر ألف خيرك. جميل جميل ده دكتور عمر. يعني الموضوع بقى سهل على الناس، وبسم الله ما شاء الله نقدر ننفذ، ولا إيه يا شباب؟ هنبتدي ناخد الأسئلة كده. راحت فين السؤال؟ Is congenital heart disease came with only tachypnea tachycardia not responding to usual management؟ هو غالبا دكتور أبو كير. دكتور أبو كير.
التاكيكارديا والتاكيبنيا, yes, it can be there, but the problem is the baby is not only tachycardic because of the congenital. Sometimes just only annoyed, stressed because someone is coming to exam, the other one need to put the stethoscope, the other one need to try to make blood pressure, the third one fix the cannula. It's not easy to differentiate. Is these things because the patient is crying because multiple procedure assessment is there, or this tachycardia is only because of the cardiac? Yes, if you exclude all the interfering factors for tachycardia, tachypnea, and this tachypnea not responding to the other support, it can be approached like the cyanosis not respond. But more objective is the cyanosis. But we can use many signs. Today, our aim is only to use more objective by simple way. That's all. Otherwise, a specialty is not only one question. Any other question?
أي سؤال تاني يا شباب؟ cut off point to start prostaglandin.
The first, we answered it, but I think it was not clear. That means the first one, if you can get the final diagnosis by echo, that is clear. Echo, they will tell you is that dependent or not. But when we have no echo or the patient start to deteriorate, it's easy. Just look to the chest X-ray. If the chest X-ray not explain the cyanosis, that means probably it's duct dependent. Give him prostatin. That's all. It's no numbers. Saturation, it can be anyone. As we mentioned it, below 90, from 90 to 95, above 95. The normal is only above 95 after the 24 hours. But others is all abnormal. The things that we can use it all, as we know, the patient is not only one finding. For example, if you have one patient saturation 90, but he is completely comfortable, yes, it could be cardiac cyanosis. But at this level with comfort, even the saturation 90, I can observe him till we get the echocardiography. But if he work hard, he's in distress, he needs some support, it's no problem. If I have no answer to the cause of distress, I can start prostatin and then wait for the cardiologist to finish his assessment. So there is no cut number for saturation, but there is cut number for your assessment. If you finish all your tools and not answering your question, yes, it's safe to put the patient on prostatin and wait for the final diagnosis. Prostatin is not bad, by the way, especially the doses 0.05 and below is not a bad drugs.
in congestive heart failure, can we give Lasix
Yes.
up to how much?
Okay. Lasix is a diuretics. And if you have congestion, you need to remove this congestion. You can give the diuretics. If you give one dose and you get the diuresis, that means the patient start to become negative. That is your target, to have a negative patient and follow it. To which point you need to be to have a negative? You know, we have a parameter. First one, the signs of over volume in the body. The second end is starting to raise the urea. So if you are in between this point, you can give Lasix 1 per kg, 2 per kg, up to 3 per kg per dose, 6 hourly. That means it's okay. In many occasions, even we can give it infusion if we think the diuresis is the solution. It's no problem. Then after you get out the over volume, then come back to the usual doses, which is 1 per kg per dose, TID or 6 hourly, depend on the age. But diuresis is our target. So we need diuresis that is removing the volume, but it doesn't cause vascular collapse to the point that affecting the renal function. This is our area. First limit and second limit.
Lactate if increased, what is the values and normal values of normal? مش فاهم السؤال.
Well, for the normal values, you can read it from any book, but usually in the practice, the normal is 2.5 and less. 2.5 and less. But more important than the number, the trend. If he has 5, then the next result is a 3. So we are okay. Even we don't reach the normal. But it's okay. Some baby they will reach to you with a 12 lactate. So if the next is 8, that means we are okay. After that is 6, that we are okay. Even we don't reach the normal, but we are in the proper track now. So we are not hurry to bring it to the normal, but we need this lactate to trend the acceptable trend.
الأسئلة كتير.
If you ask about cardiology, we will not finish unless morning, but give us a question relevant to our
طيب
lecture
احنا هناخد
only.
سؤال واحد ماشي.
Right? No,
Sometimes during observation of full term baby we find him desaturating below 90 saturation and pass already cyanotic congenital heart disease with no cyanosis upper limit saturation not more than 94. I can discharge the baby home or need echo.
it's saturation below 90.
هو we find him desaturating below 90
خلاص, how he passed the critical?
and pass already هو باص الcongenital heart disease. اوكي cyanotic with no cyanosis upper limit not more than 94. بيوصل للابر ليميت مش اكتر من 94. يعني هو بينزل ل 90 وبيطلع للابر ليميت اللي بيطلعه 94. كده يقدر يعمله ديسشارج
how
ولا
he have ما يقدر. شوف السكرينينج is 94 إلى 90. This is the gray zone. You need to repeat the test 3 times. If you have a patient continue to be in this area, he consider as a failed test. He need to go to screen. This is the definition. But discharge, that means patient above 95 and above. 95 and above. لكن I will tell you, if the patient diagnosed, for example, patient diagnosed with pulmonary atresia and MAPCAS, pulmonary atresia with multiple major orthopulmonary collaterals. This patient can be discharged saturation of 80. It's okay. But after we diagnose him, before that, no. Any patient, he failed the critical congenital disease screening. Even sometimes he failed first day, the second day, again, we know the screening in the second day. We need to send him to echocardiography. Discharge only if the patient saturation more than 90, 95 and more, and the difference between upper and lower is not more than 3%. This is the discharge.
شكرا جزيلا على المحاضرة الجميلة
بارك الله فيك.
ونسأل حضرتك أكتر من كده الأسئلة كتير على وعد بلقاء آخر إن شاء الله.
بإذن الله تعالى. بإذن الله.
شكرا لحضرتك ولتواصلك وعلى سعة صدرك. تشرفنا
الله يحفظك.
بحضراتكم.
يا حبيبي.
المحاضرة إن شاء الله يا شباب مسجلة، كانت لايف. إن شاء الله تنزع لايف ستريم تاني على حضراتكم، وكالعادة تكون على قناة الإيوبي بإذن الله. عشان
يعطيكم العافية. السلام عليكم.
اللي يحب ياخد سكرين شوتس منها تبقى معاه كجايد له، يعملها هو PDF زي ما هو حابب. لو دكتور عمر تفضل وبعت الPDF هنرفعه لحضراتكم.
بإذن الله.
شكرا لحضرتك، ونلقاكم على خير، ليلة سعيدة، وما تنسوناش من صالح دعائكم جميعا يا رب.
يلا السلام
شكرا
عليكم.
لحضرتك.
يلا السلام.